Thank you so much for being part of this session. So let's move to the case. This is one of my regular patients. I'm following her because of cataracts. She has visually significant cataracts in both eyes, and the main reason for delaying her surgery is that she's having metastatic renal cell carcinoma. So the idea was to postpone her surgery until the chemotherapy is at least completed. And we were following in this way. So this is the initial visual acuity. Around 6 months later, after this examination, this is the fundus of the patient. You can see it's difficult to see the details because of the cataracts, and the maculas are completely fine. Around 6 months later, she comes for her follow-up, and she tells me her vision is decreased, which was expected for the cataract. You can see here that there is an evolution in the opacity, but she has subtle anterior chamber cells in both eyes. No keratic precipitates, no synechias, but some cells. And when we get her OCT, this is the image of the OCT. You can see choroidal thickening, choroidal folds, and some areas of neurosensorial detachment. Furthermore, if you see her optic nerves, she developed huge papilledema. You can see here the comparison 6 months earlier and the new evaluation. She has no headache, she has no tinnitus, she has no other symptoms, but she noticed decrease in visual acuity. This is the B scan because the cataract precludes proper view of the posterior segment, and we cannot get even fluorescein angiography or ICG. And you can see that there is vitreous cells and increased choroidal thickening. And in the right eye, in this scan, you can see the papilledema. So she's having a pan-uveitis. So far, there is choroidal involvement, of course, and I didn't see anything related to a granuloma. But the patient is now on her 39th cycle of nivolumab. And I think with this medication, we can infer the diagnosis for these patients, which is VKH disease-like induced by nivolumab. So, nivolumab is part of the new drugs to treat cancer. It's an immune checkpoint inhibitor. The checkpoints are natural proteins expressed by the T lymphocytes that whenever they are stimulated, they produce a downregulation of the immune system, and they help in tolerance, in prevention of autoimmunity, and tumor cells take advantage of this pathway in order to evade the immune response. So whenever can I continue? Thank you. So these drugs are going to inhibit the interaction between the tumor cells and the T lymphocytes and will enhance the immune system. So the natural T cells are going to fight against the tumor. However, because of this, can I move one slide more? We will have immune-related adverse events in around the body, but especially in the eye. Although the frequency was supposed to be low in the eye, now we know that we are overlooking of these complications. Among the ocular complications, dry eye and uveitis are the most frequent ones. Please, one slide more. But this is the myriad of syndromes that we can have in the eye related to immune checkpoint inhibitors. One more. Thank you. So VKH syndrome, like related to nivolumab, is the first cases of VKH uveitis related to immune checkpoint inhibitors were reported with ipilimumab in the setting of treatment for malignant melanoma. But for nivolumab, there are reports in other cancers, like, for example, ovarian cancer, or the case of my patients, there are already reports in a metastatic renal cell carcinoma. It is unclear if the medication should be discontinued after VKH like uveitis, or we can temporarily discontinue, treat the patient with corticosteroids, and then re-challenge the patient for the medication. We do not have till now any algorithm for the treatment. This is just an adaptation from a cancer algorithm for other systemic manifestations of toxicity of these drugs. Usually we are going to divide in mild, moderate, severe, and life-threatening complications or death. But in ophthalmology, we're not going to deal with this kind of complications. And the idea is to discontinue the treatment and start using corticosteroids. We can start local corticosteroids. Usually systemic treatment is needed. Sometimes immunomodulators are needed. And all these treatments should be balanced towards the treatment of cancer, because the treatment of cancer looks for the opposite, looks to enhance the
Dr.
immune
Lilian,
system.
because the time is too short.
Yeah. So these are my conclusions. Further research is needed in order to develop predictive biomarkers, redefining treatment guidelines, and improving our understanding on the balance of cancer treatment efficacy and mitigation of ocular immune-related adverse events. Thank you so much.
Thank you, Dr. Lilian. It's a great. This is what we are just mentioned in the previous case, that we had now other differentials, and know that we JAK inhibitors is one of the,
If you can advise me what to do, I will be very.
But the good thing is that you are treating a patient and then you are treating your treatment.
Yes, yes.
So thank you. If there is any questions or add comments in this subject. Otherwise, we have, would like to move as fast as we can, because we have another sessions that to get in. So thank you, Dr.
Thank
Lilian.
you.